Good evening. I welcome you all to the academic presentation of registrars in family medicine. And I welcome Madam Lakmal Rathnayake to our gathering. So today's presenter is Dr. Lakmal Rathnayake, who is our batch representative also. And he's going to present on falls in elderly. Without much ado, because of we are about 10 minutes late, I would like to invite Dr. Lakmal to proceed with his presentation.
Thank you, Prabhat. Good evening, Ananta Madam and all the other colleagues. Prabhat, I think I can hear you, no?
Yeah, I can hear you, and you can share the screen now.
All right. Prabhat, can you see the slide now?
Yes, I can.
All right. Right. Good evening again for everybody. I'm going to present today the falls in elderly. Actually, this is a topic that are very much less talking in Sri Lanka and all over the world. So I'm going to start with the MCQ. So I'll give a 1 minute for you to read and Prabhat, the slides are not moving.
Can you exit and again reshare? Then it will be okay. Stop sharing.
Now, can you see the slide?
The first one I can see. Can you share it? Move it?
Yeah, all right. Okay.
Yeah, now
Yeah.
okay.
Right. This is the MCQ. Can you just go through that? I'll give 1 minute and just read the MCQ. And you can put the answers into the chat box. This is true and false question. Yes, actually, few answers came. So I think everyone has got most of the answers correct. Right, I will read the question regarding polls. First one is 30% of adults over 65 years falls annually. It is true, right? It's correct. It's all over the world. It's 30% of adults over 65 years falls annually, at least one time in a given year. In Sri Lanka also that data is available. Actually, they have done some research. It's Sri Lanka. It's around 28 to 34%. More than 65 year or older adults falls annually. Second one is the recommends to screen all adults over 65 years for false risks. It is also true, right? That is recommended. That is WHO recommendation now. They recommends that to screen all the adults over 65 years, both male and female, for the false risk assessment, right? That is recommended by the WHO now. And third answer is structural and functional deterioration of frontal lobe mainly contribute to the falls in older adults, right? That is also true answer. That is the main thing actually. In falls, mainly the falls happen due to old age. This frontal lobe activity is less after 65 years. So that is the main reason. That's why they are getting the falls. And the fourth one is false risk is high in males compared to the females in adults. That is false actually, right? Because false risk is high in females. It's around females, it's around 58%. Males is around 42%, right? So in females have high chance to have falls in older adults. And fifth one is most adults with time up and go test between 10 to 20 seconds have independent mobility. Right. Most adults with time up and go test between 10 to 20 seconds have independent mobility. Right. That is also true answer because I will talk about later in the time up and go test. But that is also true answer because even though test is more than 10, test is positive, but 10 to 20 people have independent mobility. That is also true answer. Right, then I will go to the presentation today. Prabhat, again, slides are now moving.
I think you have to reshare, no? Stop. Then.
Excuse me, Prabhat, Lakmal, have you all sent the link to the junior batch?
Yes, madam.
And have you sent to the junior batch the coordinator, Dr. Niroshini? Prabhat, can you send it to? She is asking.
Okay, madam. I will send now.
Okay, fine.
Right. Sorry for the technical error. Right. This is a case today. I think you can see the slide, and this is Mr. X is a 80-year-old patient with diabetic, hypertension, rheumatoid arthritis, and early CKD also, presented with on and off right side headache and generalized weakness for 2 weeks history. Right. Basically, this is the multi-morbidity patient presented with headache and generalized weakness for 2 weeks history. There's a history of fall 2 months back, and he has gone to the closest hospital. And at that time, he had a scalp laceration, and laceration was sutured at the ETU, and patient sent back home in 2 months back. So after that, patient was perfectly okay. He was doing his day-to-day activities. So then second fall was happened in 2 weeks back. At that time, they have not gone to the doctor. So there was no any injuries also. So patient at home. During the falls, he does not have any loss of consciousness or any generalized tonic-clonic movements. There was no any vertigo, chest pain, or palpitation at the time of falls in both occasions. And he does not have any fever or urinary symptoms or any respiratory symptoms now. And his blood sugar was normal. 2 weeks back, he has gone to this normal medical clinic in closest base hospital. So at that time, his blood sugar was normal, and he's a regularly clinic follow-up patient. And he's a farmer actually. He is farming the vegetables, and even though he's 80, he's working his farm with the help of others, and he's doing his activity of daily living as normal person. But after during last 2 weeks, he couldn't do his works, and he had loss of appetite, generalized weakness, and some unsteadiness also during last 2 weeks. Right? These are the drugs actual patient on long-term drugs. This atorvastatin 20 milligram nocte, aspirin 75 nocte, amlodipine 2.5 BD, enalaprate 2.5 BD, and sitagliptin 50 BD, glycoside 160 milligram BD, and calcium carbonate 500 milligram TDS because he's a early CKD, diabetic nephropathy, and 1-alpha cholecalciferol 0.25 daily, and the furosemide 40 milligram BD because he's having a bilateral ankle swelling also. Right? These are the drugs he's on. And now this is the basic history of the patient. Patient with multimorbidity with diabetic, hypertension, CKD, rheumatoid arthritis, and things. Came with 2 weeks history of generalized weakness. And the patient had a 2 history of false attack during last 2 months. Right? So my first thing is what could be the causes? What are the causes this patient is having to have a falls like this? He had 2 episodes of falls. So what are the possible causes on this patient? Can you just explain what are the possible causes?
Lakmal, he's on enalapril, right? It can cause postural hypotension, and it could be reason for a fall.
Yes, that is also possibility. Any antihypertensive can cause falls actually.
Polypharmacy with electrolyte disturbance.
Yes, electrolyte disturbance also possibility because polypharmacy also and the CKD also this patient that is also can cause electrolyte imbalance.
And oral hypoglycemics in the background of CKD can cause hypoglycemia.
Yes, definitely. Because he's on very high dose of glycoside, 160 BD, and he was not on metformin. So glycoside 160 BD at 8 years. Obviously, hypoglycemic risk is there.
Visual impairment,
Yes, at 8 years, that is also a possibility.
diabetic neuropathy,
Yes, that is also a common cause. Peripheral neuropathy can lead to falls.
cognitive impairment, mild,
Yes. Right. Then I will go to the list without taking much time. So these are the possibilities actually. Accidental fall also possible in the first time because he's telling that he can't remember anything what happened. He just fallen on the ground. And the neurological problems like early Parkinson's disease or any other chronic neurological disorder and all the other things they have mentioned. And the cerebrovascular accident also possible. Infection, acute delirium and things. And the NPH also, normal pressure hydrocephalus, or maybe seizure, dull onset seizure also possible. So these are the possible causes came to my mind. Actually, this patient came to my practice. I was thinking about these things. And then I did an examination. Actually, he's mildly pale, maybe because of early CKD. And he's averagely built. And he's a mild tremor. And GCS is 15 and the pulse rate is 80 and the blood regular pulse, there was no any irregularity and the blood pressure is 150/90, it's fairly okay and there was no any postural drop, no carotid bruise and the heart sounds is normal and there was no any added sounds or murmurs and the central nervous system actually vision is impaired, bilateral cataracts is there, vision is 6/16 both eyes. Even though he's working his farm and doing day-to-day activities, his vision is very poor. And the mature cataracts was there in bilateral. And very difficult to see the bilateral fundi also. And there were bilateral hearing impairment also. But other cranial nerves normal. And the gait was broad-based gait, unsteady gait. And the neurological examination, bilateral upper limbs, power, tone, reflexes normal. Bilateral lombal, right-sided power of 5, left side also a little bit less, difficult to elicit, but I think it's little low compared to the right side. Lower limbs, tone, reflexes, and plantar response is normal. There was no any cerebellar signs. Peripheral sensory loss is present, maybe because diabetic neuropathy. And there were some foot deformities, mainly because of diabetic. He's having diabetic more than 20 years. So Charcot joints and hematos are there. And minimental examination, it's score around 21. 21 is a mild cognitive impairment. Up to 24, it's normal, like 24 to 21, it's mild cognitive impairment. 23 to 19, up to 19, it's mild cognitive impairment. So this is he had mild cognitive impairment. And time up and go test is 75 seconds. It's normal value with 10 to 12, but it is very much high. Bilateral knee joint swelling is there and knee joint little deformed. And other joints normal except that foot joints having the diabetic changes. Right, now this is the story actually, history and examination. Now this patient came to actually to me in my practice. So what is your plan? How do you going to manage this patient? This patient, 8-year-old, came with generalized weakness 2 episodes of falls during last 2 weeks. And the examination, we couldn't find anything much actually. Now, what is your plan? Can you explain what is the plan? How are you going to approach to this patient in your practice in primary care?
Lakmal is still the hyponatremia or electrolyte imbalance is higher in the list, and also visual disturbances was there. That also we have to consider. Other that I feel that too comes higher up the list.
Okay.
So we have to do other thing, blood sugar, hypoglycemia also still possibility. So
Right.
better to start with some, the blood sugar and electrolytes mainly. Then that's those things should start initially. And
You want to do the investigations,
yeah,
right? Blood sugar and electrolyte mainly.
yeah, mainly, yeah.
Okay. Any other things? Any other things you want to do?
Yeah, other thing that the test, that posterior column, did you check that? Examination part.
No,
the wash basin
that means
sign.
rhombus.
Yeah.
Rhombus negative. Yes.
Yeah, the neuropathy part also should be
Yes,
there.
peripheral
Yeah.
neuropathy is there, but there was
Yeah.
no any other sensory impairment.
Yeah.
And this patient's drugs should be revised. And as he's a patient, patient who's 80 years, I think we as a primary care physician, we should talk to the family members as well. He's 80 years and have a significant frailty according to you. So we need to talk to the family members. He's working in his farm, and for the patients who are old and who's frail, there should be some support. The other people should assist him in walking, or there must be someone beside him. Even when he's walking inside the house also, there should be someone who's going to look after him. And also we need to address about the nutrition and all the things we have to talk to the family members and to the patient.
Yes. Now this patient came to you in your practice in primary care. So what are you going to do? Are you going to change the drugs and educate family members and plan the investigations and review the patient? Is that so? How long you are going to review?
We can discuss with the family and the patient whether they are happy for a geriatric referral, falls clinic assessment.
Okay.
If that is available, so that will cover most of the causes, and also falls prevention at home. Advise them regarding that and get the multidisciplinary team organized, or DPT and things, depending on their finances and resources.
Right. Right. Actually, this is what I have done in my practice. So I have arranged some of the investigations because previous our list. So I want to exclude at least few possibilities. So full blood count, UFR, CRP, I have done whether he is having any infection going on. Even UTI, even any chest infection is possible at this age, causing this type of problem. So, and the sugar, obviously, and the renal function test, electrolyte, and ECG. These are the available investigations for us. Urgently, we can get it done. So, I have planned these investigations. So, I have reviewed the patient in the evening with these investigations. So, investigations came like this, right? HB is 9.7. That is definitely because of maybe early nephropathy. WBC is normal, 6.3 platelet okay. UFR 2 to 3 pus cells, and I don't think it is very significant. Tender blood sugar is normal, 157. Serum creatinine is 1.4. It's marginally elevated because he's having early CKD. Sodium is 132. It is little low. It's less than 135. But 132 is, I don't think, causing this much of problem. And the potassium in 5.1. But 5.1, I don't think it will cause any cardiac toxicity or anything. ECG also normal, does not show any hyperkalemic changes. And the CRP is 12. So now, what do you think? Now, what is the next plan? Any idea? Or stick into the previous plan? Because investigation does not reveal much, I think.
Basically, investigations seems normal.
Normal, according to him, yeah. This potassium sodium values, all over the clinic values are same like. So I don't think I could get the more information about this. And still our possibilities, all possibilities possible. I think infection we can exclude because CRP normal, WBC normal, UFR normal, but other things still possible. So then what I'm going to do, this patient came with 2 history of falls, and then during second fall, that patient condition become worse because after first fall also he came and worked in the farm, but after during last 2 weeks he has weak and some unsteadiness and generalized weak. Right. So we'll keep it like, then we'll talk about few things about falls, and we'll come to this story again few minutes time. Right. So we will discuss a little bit about the fall. Actually, falls is the event which result in person coming to the rest unintentionally in the below level where he was on. Right. That is the definition of the falls. Right. Actually, falls is a geriatric syndrome. It is falls is not only one causative thing. Just we can think that because one person has goes to the bathroom and he has slipped and fallen on the bathroom, but even though we think in superficially and say that it's a accidental fall, but in falls in elderly, it is a geriatric syndrome, right? It does not cause due to the one reason because it is multifactorial thing. That's why they call it fall in elderly is a syndrome, right? And the falls is one of the leading cause for the death in older adults, right? And little bit about epidemiology. I told this in the MCQ also that 30% of adults over the 65 years fall at least once a year, right? And it is the 5th leading cause of death in adults, right? Accidental falls are the 5th leading causes of death in adults. And more than 50% of fractures in older adults are due to falls, right? And 50% of traumatic brain injuries are due to falls, actually. And according to the last WHO report, 684,000 deaths are due to falls in each year. So that is actually, this is very big thing. Mainly should have addressed by the primary care physicians, right? So actually again same thing, the above 65-year-old adults, the 30% they fall, right? And if it's came to high like 70 years, so it's close to the 50%. And if it's close to the 80 years, it's actually around 100% because everybody is falling in a year if more than 80 years, right? And the mortality rate also, it's going up when the age is advanced. The mortality rate also going up because that we know that older adults also have high risk for the falls, high falls risk. And at the same time, high fall risk is there in the kids also, 1 to 3 years kids. So they have high falls risk. Even athletics have high falls risk. But athletics and the kids does not got such a mortality rate compared to the older adults. That is because they have mechanisms to overcome that falls. They have a protective mechanisms which are working very well. But the problem is older age, those mechanisms are not working. So they are more prone to have a more legal injury, more dangerous injuries compared to those groups. Right, so a little bit of pathophysiology, because brain aging is the main problem. Actually, I have discussed this in the MCQ also. What happened after 65 years, brain starts to shrink. So what happened in each year, 0.2% volume shrink in the brain. So brain volume reduce when our age is advanced. So then the intracranial pressure also reduce. So that brain volume also reducing and the brain function also reduce. Because of that, mainly that frontal lobe structurally and functionally, that is deteriorating because of when we are getting the advanced age. So that mainly the frontal lobe responsible for the motor activities. So that will lead to falls. So that is very high risk. The brain aging will cause the falls, increase the falls risk. When our age is advanced, we are more prone to lose our muscle mass. That's called sarcopenia. So, and they lead to have a neuromuscular impairment and instability. So this is just like a vicious cycle. Then fractures and falls. Then again, patient due to the falls, patient become immobilized. Again, immobilizing, causing sarcopenia. So this is just like a vicious cycle. We are prone to more falls, right? So actually causes like there are so many causes for the falls, but in the higher up list, it's accidental or environmental causes. Actually, this is a multifactorial thing. We can't say it's exactly one cause, but roughly we can say accident and environmental causes are high, and the gait and balance disorders around 17%, and other specified things means heart irregular rhythms or maybe other seizures or things like that. And the dizziness, vertigo responsible for 13%, and the visual problems 3%. Likewise, these are the causes. And these are the causes. Actually, we can divide into so many ways. This is one way we are talking about potentially modifiable risk and non-modifiable risk, right? So I am not going to tell about all these things, but you can see that cardiac causes are there, cardiac arrhythmia, heart failure, and hypertension. Environmental hazards there. So those are potentially modifiable causes, right? Metabolic things, skeletal problems, neurological things, and the psychological depression, and sensory impairments, and acute illnesses, and cancers. All these things are, we can potentially modified causes for the falls. And there are non-modifiable causes also, risk factors, non-modifiable risk factors also, because age, race, sex, we can't change these things. And any history of falls, that is also responsible for the falls risk, right? So this is one way we can divide the risk factors, right? The other way is the extrinsic and intrinsic factors. Extrinsic factors are the environmental causes, environmental risk factors, and the drugs, medications. Those are extrinsic factors. All the others are belongs to the intrinsic factors like neurological impairment, musculoskeletal disease, all those things, vision, all those things are belongs to the intrinsic factors. Then medications, little bit about the medications. So all these lists are responsible for the increasing falls risk, but benzodiazepines are the highest in the list. They are more prone to get the falls, increase the falls risk. And if the patient is on more than 4 drugs, that itself is a risk factor, whatever the drugs. if the patient is in the more than 4 drugs, that is a risk factor for the falls. And the anticonvulsant, antidepressants like tricyclic antidepressants, SRI, and then any antihypertensive, any Parkinson's, antiparkinson like digoxin, diuretics like furosemide, all those things are responsible for the increase the falls risk, right? And what happened actually, all these falls risk factors are responsible by the falls. So after falls happen, there are some outcomes also, right? It may be physical problem, it may be mental problem, it may be social problem, right? So the outcome is also there after falls. So it's very bad outcome. Physical, there may be some abrasions, bruising, fractures, so even death can occur, right? And the mental, so after become fall, so they will have a depression, and they are become more fear to falls again. So they are in very fear to walk and fear to go out. And there are so many social problems. So he become immobilized. In that case, there are economical problems and patient can't go out. They can't do the jobs and things. So there are so many social, mental, physical problems due to falls, right? So now how we are going to address this fall, right? At the beginning, so what we have to do, if the patient comes with falls for your practice, so you have to sort out at the beginning initial problems. Acute problem we need to sort out. So we need, if the patient comes with falls, then if there's a laceration, we have to suture it. We have to, if we are suspecting any stroke or something, we have to do the CT and things. We have to sort out the acute problem. After that, this is how we are going to address the falls, right? So there are 3 main philosophies. So one is the way, one panel is we need to screen the patient, right? If WHO recommend that all the older adult more than 65 years, we need to screen, right? So there are screening tools. So I will discuss this later. The screening is the one arm, right? After screening, if you have identified the person as a having a false risk high person, then we need to assess his modifiable and risk factors we need to assess. Then we need to intervene. We have to intervene clinical and community strategies to prevent further falls or any falls in the future, right? So these are the strategies we need to address to falls prevention: screening, assessment, and intervention, right? These are the main 3 things we need to address. Assessment of fall risk, again, I told this, all the people above 65 years, we need to assess for the fall risk, right? This is the 3 questions that we are using for the basic assessment, right? This is very acceptable questions. So number 1 is, have you fallen in the past year, right? Then second one is, do you feel any unsteady when standing or walking? And third one is, do you worry about any falling? So to ask these 3 questions will not take at least 10 to 15 seconds, right? During our practice, if anybody comes with 65 years or more, we can ask this question. If any one of these questions patient become yes, then that patient is having a high falls risk. So we need to assess this patient's balance and gait, right? So there are special tests for the to assess the balance and gait. So that warrants, if any one of these questions patient become yes, said yes, then that patient is warrants to have those balance gait and balance test, right? So this is the other thing. This is self assessment questionnaire, right? This is there are 12 questions. So this is well accepted questionnaire. So they are giving the marks. So if there are 12 questions, patient can answer himself. And if the patient has more than 4 points, so that will warrants to go to the doctor to assess his false risk, right? It's similar to previous 3 questions. This is voucher used for the self-assessment of false risk, right? If it score more than 4 points, patient should have go to the doctor, right? These are the tests that are recommended to evaluate gait strength and balance, right? So mainly one of the very important tests is the time up and go test. Time up and go test is a very important test that is they have recommended to evaluate the gait strength and balance. And there are two other tests, 4-stage balance test and the 30-second chair stand test. Those are optional, but time up and go test is the very important. We can get a lot of information, right? There are some other tests also, gate velocity test, and there are some other also, but I think these are the main tests they have recommended, right? This is time up and go test. So what they do is we ask patient to sit on a chair around 1.5 feet height. So then we ask patient to stand up and walk 3 meters or 10 feet and turn back and come to the same place. So we'll start the stopwatch when patient start to stand. So after patient becomes sick, so then again we can stop the watch and we can see how many seconds he has taken to finish this task. So this is what the test. So if it's the less than 10 seconds, it is normal, right? According to the age, there will be slight variation, but even in the 80-year-old patient, that should be finished less than 12 seconds, right? 10 to 20 seconds, it's mostly independent. So they can raise the staircase, they can go out independently without anybody support. So 10 to 20 also mostly independent. But 20 to 30, it's maybe variable. Some 20 to 30, some can raise the staircase, but some cannot. It's variable. And if it is a more than 30, definitely their mobility is impaired. So they need help. Definitely they need help for go out, sometime for their day-to-day activities. Everything they need help. Actually, this test is very good test. It has a 88% sensitivity and 94% specificity. And mainly this test measure gait and balance mobility, right? Assess the gait and balance mobility mainly from the time up and go test, right? It won't take more than 1 minute. Actually, we can perform in our practices, right? 4-stage balance test, actually simply it is 4 stages like this foot marks. We ask to patient to stand like this, and we ask to patient to stand for 10 seconds. If he can stay in that position 10 seconds, we upgrade him to the that second step, then third step likewise. If patient cannot stand more than 10 seconds in one stage, so that is means 4-stage balance test is positive, right? This is also we can perform mainly they assess the static balance here. 4-stage balance test, they assess the static balance, right? The other test is the 30-second chair stand test. What they ask to do is we ask to patient to sit on a chair around 1.5 feet. Then we ask to stand up and sit down to the patient within 30 seconds. We start to calculate the time and we ask the patient to stand and sit. And at least patient should have do the 40 stands up, right? If it is, there's chart, if it is 65 to 69, it's 12. It's likewise, it's become reduced, but at least patient should have, if it is more than 65, at least patient should be able to stand 10 times, do this, right? Otherwise, we can take it, the test is positive. These are the 3 main tests that we are using to check the gait and balance, right? These tests are used to assess the gait and balance. If that previous 3 questions, at least one of these questions positive or that voucher score more than 4 points, patient sent to these 3 tests to assess the balance and gait. So that is how we assess in the false risk screening we are doing. So if any one of these positive, so we have to send the patient to the assessment. Right. So that is about false. So now again, I would like to come to our case, right? Just to remind, I put the investigations again. Investigation almost all okay. And the patient's condition is same, right? It don't change. In the evening, patient came with this investigation. Patient is still in the same. And I suggest him to admit actually, but they are strongly refused. Actually, my point is to admit because his unsteadiness and generalized weakness during after second fall, and patient is little unsteady and some weakness in the left side also, little weakness, but I think something in the brain, so higher in the list. So then I asked the patient to admit, but patient is strongly refused to admit. Then I plan for the non-contrast CT brain from the closest private hospital, right? So this is the non-contrast CT brain. Patient came in few hours time with the CT report. So what you can see, can you just say what you can see in the CT?
Is it SDH? Lakmal?
Yes. You can see it's SDH, right? Actually, report, the patient came with the CT, but they have issued the CT report in 2 days time. So this is what the report says. Radiologists mention it as a right-sided subacute on chronic SDH with a maximum thickness of 28 millimeter. Adjacent right frontoparietal lobes are compressed with mild compression of anterior horn of the right lateral ventricle, but no midline shift or significant cerebral edema. Right, it's 28 millimeter thickness SDH, and it compresses the adjacent frontoparietal lobes also, and it's right-sided subacute on chronic SDH. Right, this is how the report came. So then actually this time I actually from the plain CT patient came without this report. So after that I admitted patient to the NHSL. So patient has directly gone to the neurotrauma unit at NHSL. This is what the discharge records. So they have done a Burhole aspiration 2 days later after admission. 2 days later, they have done a Burhole aspiration and removed all the blood. And at that time in the ward, so all the parameters are almost same, nothing much difference. And his weakness also improved at that time because lower limb also there's no any weakness. And they have discharged patient 2 days after the Burhole aspiration. Right. So after that, patient came home and patient asked me to do a home visit. Actually, this is, I have taken the permission from the patient to add these photos. So this is the patient actually. So after surgery, 2 days after came home, I did a home visit. So you can see patient is little less active now because he's working in the farm previously. There are a lot of steps in the, so those are also risk factors, environmental risk factors. Actually, this is the place where first fall patient, this first step where he stand close by. And I went to this room also. It is fairly okay actually, but floor is little slippery because of the tile. And there's no any closed bathroom, but other things, I think less furnitures and things. That room is, I think, fairly okay. Right. Now it's a little bit about chronic SDH. Actually, chronic SDH is an abnormal collection of liquefied blood, degradation underneath the dura mater. So that may result in compression of the brain matter and causing some focal neurological deficit. That is what the SDH is. Actually, it is very common in elderly, and incidence is 13.5 per 100,000 population, and it's become 58 when they close to the 85 years. SDH we can classify according to the type. Acute SDH, so that means within 3 days of fall, we found that that is called acute SDH. Subacute is 4 to 20 days after fall, and the chronic SDH, if it is more than 21 days, we call it chronic SDH. But our patient had subacute on chronic SDH, so that means he must have start bleeding at the first fall 2 months back, and the second time also again he must have bled after second fall also. Right, this majority are due to trauma, mainly accidental fall and trauma, and other causes may be intracranial hypotension. Intracranial when we advance age, that brain becomes shrink and our intracranial pressure become low, and spontaneous intracranial hypotension may develop. So that also can cause some SDH, right? And some coagulation problems also can lead to SDH. These are the causes for the SDH. And this is how you can compare the SDH and the EDH. Actually, SDH is a venous blood. It's mainly from the bridging veins in between the brain and the skull. There are from the dura mater and the arachnoid mater, there are veins. So bridging veins, these veins can disrupt and can bleed into the under the dura mater. So subdural space they will be. So that is a venous blood. So that won't cause much pressure. So it won't present acutely normally. But in the epidural, it's arterial blood. So that shows as a convex shadow in the CT. Right? This is SDH is mainly concave shape. Right? The other risk factors for the SDH is the age is one of the main risk factor, because when the brain is shrink, that bridging veins are very mobile and they are more become more tense, and they are more prone to can damage even in the small traction. They might bleed and they might track. And the trauma is definitely it's a cause for the SDH, and the coagulation problems, even therapeutic, maybe aspirin, clopidogrel, warfarin, whatever the things causing coagulation problems that can cause SDH, and the alcohol abuse, they can lead to the SDH, and the patient on CSF SUNS, they also lead to SDH, right? Clinical presentation of the SDH, actually, sometimes it may be asymptomatic. Right? If it's a mild, less than 1 centimeter thickness, it may be asymptomatic, and it vary from mild headache, seizures, or decreased memory, confusion, or some other focal neurological signs, even death. Right? This is how SDH can present. Right? So this is in the CT. You can see in the acute SDH, it's hyperdense. It's white in color blood in the non-contrast CT. But when it's come to the 1 month, because sometimes we might, in our patient, we have got it to know in 2 months time, right? In 1 month's time, it's like isodense. So it's same in color, and it can miss also. In the it become hypodense when it's close to the 2 months, right? In our patient, like it's like hypodense area SDH, right? And the management wise, actually asymptomatic patients less than 1 centimeter diameter SDH, we can be managed conservatively. We don't want to do any burr hole or any interventions, but mainly SDH is managed by surgically. It's burr hole aspiration or craniotomy, and we need to remove the blood. And we need to address the coagulation problems. If there are any thing prone to coagulation, we need to think about antiplatelet drugs and all that. And if the patient is more prone to have risk of seizures, we need to start some anti-epileptics also. Right. So this one I'm not going to talk about much. This is how we are going to intervention to the false prevention. Right. This is what we can do in our practice. So what we can do is that we can ask that previous 3 questions from anybody more than 65 years. At least if one of these patients say yes, we can do that previous test, time up and go test or other 2 tests to assess the balance and gain. If there is any instability or any test become positive, then that patient warrants to have a the multifactorial risk assessment. Right? We need to do the multifactorial risk assessment if their balance test is positive. Right? So how we are going to do that? This is how multifactorial risk assessment we are going to do. So we need to take the full history of fall history, in detail history we need to take, right? We have to assess the gait, balance and mobility and muscle weakness. We can do those tests and we can check the muscle strength and things. And we need to assess the osteoporosis risk. An assessment of the older person's perceived functional ability and fear related to the falling. And we need to check the vision also, right? And cognitive impairment we need to assess. We can use the MMSE or some mini-cog, and we need neurological assessment also and musculoskeletal assessment. And like we discussed in the previous week, we need to assess whether patient is having any urinary problem, urinary incontinence, which are more prone to have a falls. And we need to assess the environmental hazard, home hazards, how is the lighting, is flow, and the bathroom facility, all these things, any steps we need to assess. And we have to do the medication review and cardiovascular examination also. This is how we are going to do the multifactorial risk assessment if the patient is having the balanced and gait assessment positive. Right? If we have done a multifactorial risk assessment, then we need to do the false prevention, individualized false prevention interventions. We need to address these problems. We have now we have do the multifocal risk assessment, and we have identified some of these problems. Just say we have identified poor vision, maybe poor hearing, some environmental factors. So we need to address these problems during the intervention. So all these things we can do as a primary care physicians, right? Actually, this intervention should be done as a multidisciplinary approach, but it's not happening in Sri Lanka. That's true, but this is how what will happen in other countries. So mainly these multidisciplinary teams are led by the GP or the primary care physicians, and it will include all the other workers. It will include the physiotherapists, occupational therapists, social worker, and some caregiving nurses. All this staff is involved for the multidisciplinary approach. And number 1 is we need to educate the patient and caregivers and relatives. And if there's any vision problem, we need to refer them and correct the vision. We have to do the cataract surgery or some glasses. We have to do that. And we can refer, if there's any gait or balance problem, we can refer to the physiotherapist, and he can do the balance training exercises, and that will show that balance training exercise will reduce the falls risk of the patient. So that is proven in research. And we can refer to the occupational therapist. So he will go and assess the home safety assessment, and he will do the needful. What are the environmental modification that can be done? So he will arrange that. And as a GP, we need to review the medication. Actually, what I want to tell you is that even though this patient has done a surgery and sent back home, I went to the home visit and checked the list. What is the now this patient's drug? Because he's on the glycoside, very high dose, furosemide 40 BD and things like that. But still the patient is on these drugs. So I think secondary care is not going to address this prevention part. So this is a primary care physician's role. So I think we have to do that. we need to review the medication, and we can de-prescribe some of the drugs. We can reduce the doses. We can give some other alternatives also as a primary care physician. And we have to assess the osteoporosis risk, and we can do the DEXA scan. We can give some vitamin D, calcium to prevent the osteoporosis. And we can assess the postural hypertension, and we can alter the drugs and do the needful to prevent the postural hypertension. And medical management, we need to optimum medical management. We can refer to the relevant authorities. If there's any neurological problem, we can refer to the neurologist. Likewise, we can address this problem. And if there's any food problem like this patient, so we can refer to the for the special source or anything. And other very important thing is that there are psychological part, because after become fall, this patient become fear of falling again. So that will affect her day-to-day activities also. And we need to give them a social support and economical support. So this is how we have to do interventions to prevent falls in future, right? Right. This is my slide, last slide, actual take-home message. Number one is WHO recommends that screen all above 65 years of age to assess their falls risk. And identify people, second one is to identify people with risk of fall. It's easy actually, and apply them to prevent the falls, apply them for the interventions. And the other important thing that we have to remember is SDH is very common in elderly, and it can be present in many ways, even with asymptomatic patients and very vague complaints. So these are my take-home messages. So thank you very much for listening my presentation. Any questions you can ask. It is open for the discussion. Any the way I have managed this patient also, because sometime you would have sent this patient at first presentation to admission. So likewise, so you can say anything. Hello, Prabhat, you can hear me, no? Hello?
Yes, Lakmal, I can hear you.
Seniors don't have any questions? Any clarifications regarding the history and the sort of his justifications? Do you have any queries? There are seniors, the acting consultants that's also there. Do you need any clarifications regarding the this patient, not the presentation, their justification for each and everything?
Good evening. I am Dr. Keerthi. What is the reason for first fall? The speaker.
Yes, I think, yeah, first fall, I think it's an accidental fall. that I showed that step. He has fallen from that step, first fall. But he can't remember that, but relatives tell that patient is fallen on that step. I think that is a accidental fall in the first one.
Lakmal, how could you say this is an accident? This is still, it's again sort of multifactorial.
Yes, madam, yes.
Yeah, we cannot say it's still, it could be chronic SDH even, because
Yes.
brain atrophy is associated with chronic SDH. So he might have a little bit of things because of the brain atrophy. There should be some bleeds, that's you highlighted correctly. The brain atrophy itself can cause this thing, right? So it could be this, then there are a lot of things, right? And good that you highlighted the Kirtis. We cannot pinpoint and say the reason for fall is this. That's why it's just, if it is just one reason, we can nicely treat the patient. Since it is not one reason, since there are multifactorial, that is why we need this much of assessment. Right? So you treat just one cause will not help. Then reasons, causes for falls, as well as repercussions for falls. So, and preventions for falls. Those are the three main things you should address. And Lakmal, regarding this patient's history, you mentioned that particular patient, this particular, like 84-year-old, I think 84 is 80, I cannot remember.
80, madam,
80 years, he has a CKD.
Yes, madam.
What are the evidence to say that he's having CKD?
Madam, serum creatinine is marginally elevated, it's around 1.4. Other than that, they have done a ultrasound scan 2 years back. It says some chronic parenchymal renal disease, most probably diabetic nephropathy. But it's a very stable CKD, madam.
Right,
It
now
won't go up.
tell me, so what is the definition of CKD? So that is, there are a lot of things you do mistakes, because there's over diagnosing CKD at the moment. I know the medical officers for each and every high serum creatinine, without like the standards, like sort of sometimes with fasting, dehydrated kidney, just check the function of the dehydrated kidney, so much of things, right? So because of that, I ask you all to go through, and is a homework to get how do you diagnose CKD? What are the criteria to diagnose CKD? Because old age,
The rifle criteria, madam. TFR and
rifle criteria. Yeah, just tell me. Yeah, just Ashini, yes, good. That's your highlighting. Yes, tell. It's rifle criteria.
There are 5 stages. It has eGFR has to be below 60 with evidence of proteinuria in the urine, or ultrasound evidence. I can remember properly.
Yeah, that's what you are not like very like sort of sure about it. Is though, and everybody should go and read what is rifle criteria, and this, because I see a lot of medical officers, including you all, like say it's CKD and loads with all the medication. And second thing, you mentioned Lakmal, the patient is on Lasix, the furosemide, and it's because of edema in lower limbs. Do you want to, withdraw from this particular statement, or you want to rephrase it?
Those drugs when a patient on furosemide,
How do you say that it is due? So if for the lower limb edema, so then anybody, like any seniors, could you please talk about that?
Yeah, lower limb edema can be anything actually. We have to see.
Of course. because lower limb edema, that's, like then we have to, because you cannot say no, because I have done this lecture for you all as ADFM, as MD. So edema in the lower limbs, it could be due to several factors. If it is localized gravitational edema without any systemic like sort of symptoms or the signs. So it's maybe due to local causes, like maybe old age, incompetent veins and muscles, maybe CVA can causes like burns, a lot of things. And we never give frusimides for such patients, for lower limb edemas. That's, of course, you just go and have a look. I've told you all, because the frusimide, that's what I'm telling you all. Somebody has diagnosed, maybe it's not the diagnosis of according to the rifle criteria, the CKD, and because it's a cocktail, they have given 1-alpha cholecalciferol and calcium carbonate, as well as on top of that, Lasix or the furosemide. That could be, maybe it's maybe thinking that is CKD. Right? So this furosemide can cause a lot of issues. Then it can cause postural drops and can cause falls in elderly. So it's a major risk factor. So I think, as the next day, somebody should sort of do a presentation regarding CKD with all this rifle criteria and everything. I think it's better, because I see every day, I must say every day, the medical officer unnecessarily send patients thinking they CKD, like over-diagnosing CKD, right? Okay, so that is second question. And okay, and mainly I must say, it's a good presentation. Yeah, okay, fine. But only thing, so that the justification for each and everything is not correct, as I mentioned, as well as all the time when you say the other mistake you told, it could be CVA. So what is the definition of CVA? Again, I'm asking. So don't do this type of mistakes. What do you mean by CVA? What is the definition of CVA?
It's a permanent neurological deficit, mainly due to a vascular cause.
Yeah, its definition is not that. So you better have a global thing. Better go and have a look. But anyway, this particular patient, if it is a CVA, you must know the right sort of residual neurological deficits, right? But if it is this much of repeated falls, it could be, I have seen patients with repeated TIAs. It could be repeated TIAs, not repeated CVAs. If it is repeated CVAs, definitely, or just a CVA, you can see some like residual neurological damages. So those things is very important when you use those words, because you are registrars, you have the knowledge, you have to show your knowledge, right? And those definitions, when you use a word, try to just go Google it and say, what's the definition? Am I doing correct? Right? So those things for you all. But anyway, but other than this particular thing regarding the history, other than that, your presentation, everything, the false risk and everything is good. And I'm not telling that it's bad. But anyway, when, if even at the exam you make these mistakes, then they know that you do not know the subject. Because of that only I just want to correct you all. Right? Okay, it's very good. Any other things you want to talk about? I think Dr. Niroshini is also there. Niroshini, how many people from that junior batch? Because I think Niroshini, you must be here. I think after 2-3 sessions, we'll ask these junior people also to join and do their presentation of their orientation program, I suppose. It's good for them. Okay, Niroshini is there. I saw here her name. She left, must have left. Okay, fine. Now, since you don't have any questions, you better like continue thing or write the thing or finish the thing or whatever. Don't waste your time.
Okay, thank you, madam.
Thank you very much, madam. I think we have come to the end of the presentation. Thank you all for joining.
Thank you.
Thank you, madam.
Thank you, madam.